Hi everyone, my name is Kaylee, and for those who don't know me, I'm finishing my master's up this semester, and my project is titled Predicting Outcomes for Patients with Prostate Cancer using Gallium-68 PSMA PET CT Imaging. I would like to say a huge thank you to my supervisors, Dr. Kendrick, Professor Martin Ebert, and Dr. Hassan for being such an incredible supervisory team over this last year, and I've learned so much from each and every one of you, so thank you very much. So we'll start off by taking a look at prostate cancer. So prostate cancer is a very common disease with more than 24,000 new cases diagnosed in 2022 alone in Australia. This makes up 27% of all cancer diagnoses in men. Now, when the disease is in its local state, we have close to 100% survival rate. However, when the disease metastasizes or spreads to other parts of the body, unfortunately, the survival rate drops to just 30%. 70% of men will not survive for more than 5 years post-diagnosis. This makes it the second leading cause of death in men following lung cancer. As we can see, there is high mortality and also high morbidity associated with this disease. So there is certainly research to be done to try and improve these survival outcomes for these patients with metastatic disease. So let's talk about the prostate-specific antigen test. So the prostate-specific antigen, PSA, is a protein which is found in the blood, and it's produced by normal and malignant cells of the prostate gland. The prostate-specific antigen test is a simple blood test which looks for elevated levels of PSA, as this may indicate prostate cancer. Now, PSA is non-specific, so it means that non-malignancies may result in high PSA, and malignancies can result in low levels. So, for example, other levels of high PSA are enlarged prostate or prostatitis, rigorous exercise, sexual activity, or a digital rectal exam. So because of these reasons, PSA is not used for screening for prostate cancer, but it's rather used to monitor the PSA levels of a patient post-diagnosis. So this brings me to biochemically recurrent prostate cancer. So biochemically recurrent disease is marked by rising PSA levels following definitive treatment during local therapy, such as surgery or radiation. This disease state affects 20 to 40% of prostate cancer patients, and is often a predictor of future metastases. It indicates that residual cancer cells may still be present in the body and producing PSA. At this stage, the tumors might not be large enough to be seen on imaging, but the cancer could be picked up based on this PSA test. So the person on the right here, the patient here, they have biochemically recurrent disease, and they have progressed to metastatic disease as shown by the lesions over here. Right, so how do we image metastatic disease? Well, we have something called PSMA PET CT imaging, which comprises of CT scan. CT scans have high anatomical accuracy, high resolution. However, it is often difficult to identify where the lesions may be using just a CT scan alone. As we can see looking at this patient, it's quite difficult to see if there are lesions or where they may be. The next part of this image is a PSMA PET scan. So PSMA is prostate-specific membrane antigen, and this is a protein which is overexpressed in prostate cancer cells. So when we bind a radioactive tracer to PSMA and administer that to the patient, what happens is the radio tracer will seek out those regions of high activity and identify tumors within the body. We then combine that with PSMA PET CT. We combine the PSMA PET with CT imaging, and this becomes the gold standard. So the FDA actually approved the use of PSMA PET CT imaging in 2020 after many studies showed that it had higher sensitivity and specificity compared to traditional methods such as CT or just bone scintigraphy. So looking at the patient cohort in this study, we looked at 238 patients with biochemically recurrent prostate cancer, some with metastases and some without. The patients were imaged using Gallium-68 PSMA PET CT imaging at baseline, and then most of the patients also received follow-up scans at about 6 months later. About half of the patients had received radical prostatectomy in their local disease state, and the other half had radiotherapy to the prostate. The patient cohort was very heterogeneous in terms of the treatment that they received, with some receiving androgen deprivation therapy, further radiotherapy, chemotherapy, further surgery, or just active surveillance, and also combinations of these. So over the course of the master's, I had 2 aims. So the first aim was comparing radiomic, clinical, and combination models for overall survival prediction. So let's first understand what is radiomics. Well, radiomics is defined as the extraction of large volumes of advanced imaging features from medical scans. So the typical workflow for extracting radiomics features is first we acquire the images, and then either a nuclear medicine physician or automatic methods will segment the lesions within the patient. From these lesions, we will extract radiomics features, and these typically come in the form of first-order features, such as minimum, maximum, or mean pixel intensities, or, for example, the uniformity of pixel intensities. We have shape-based features. This could be volume, surface area, sphericity, etc., and also textural features, which are a little bit less hard to conceptualize. But for example, we have run length non-uniformity. So this is looking at the lengths of consecutive pixels with the same pixel intensity, or dependence entropy, which is essentially a measure of randomness or complexity within that region that has been segmented. We can then use these radiomics features to try and create predictive models, for example, for predicting overall survival. Okay, so looking at the methodology for the first part of the analysis, we looked at 180 patients from that original cohort with metastatic biochemically recurrent disease. And the goal here was to find which features were correlated with survival time. So first, the patients were imaged, and then the lesions were semi-automatically segmented using a threshold of 3 SUVs by their body weight. And then these segmentations were then corrected by a nuclear medicine physician. From here, radiomics features were extracted from the largest lesion in that patient. And then we used those features in combination with clinical features such as age, weight, PSA tests, Gleason score, etc. And we tried to correlate individual features with the outcome, which was survival time, using Kaplan-Meier analysis and univariable Cox proportional hazards models. So the patients had between 1 and 35 lesions with a median of 2. And as mentioned, only the largest lesion was used for this univariable analysis. So looking at the results, we found that many features were in fact correlated with overall survival. So 68 out of 89 radiomics features were correlated, and 6 out of 8 clinical features were. And what we see here is Kaplan-Meier curves for 2 of the radiomics features. This one is total lesional volume. What this shows is that those patients with a higher volume, marked by the purple, have a poorer survival probability compared to those with a smaller tumor volume. And the same pattern was observed in the randomness of the pixel intensities. We see the distinct separation between the 2 groups, marked by the log rank test with a p-value less than 0.05. On the right are the results of the clinical features. So we had 8, and we see that both weight and Gleason score are not significant. They cross over that 0 line, but each of the other features were in fact significant in terms that they were correlated with how long the patients lived. Okay, so the next part of the analysis was a multivariable analysis, so combining the features together into models. So for this part, radiomic features were extracted from the largest tumor in each patient, the hottest tumor in each patient, and this was marked by the highest SUV value, and the weighted average of the largest 3 tumors to try and get a better understanding of the overall disease burden in the patients. So using some sample size calculations, it was determined that 6 features would be best for less than 9% mean squared error when we have 180 patients going into the models. And then 13 separate models were compared. So the first was a clinical feature only model. The second was a radiomic feature only model, and there's 3 for the 3 tumor types. And then we have 9 combination models using varying numbers of radiomic and clinical features. And then concordance indices with 95% confidence intervals were calculated and corrected for optimism, which essentially prevents, it accounts for some of the overfitting that has happened. So this was done using bootstrapping techniques, where 180 patients were randomly sampled each time, and it was repeated 1,000 times. And the reason for this is to try and better mimic the variability in real life patient cohorts. And because we had 1,000 iterations, we could then get this 95% confidence interval from the results. So here are the results. What we see is that the clinical feature only model has performed better than all the other models. So the C index is here on the right, on the left with the confidence intervals. So the features used in that clinical feature only model was conventional staging, age, Gleason score, number of lesions, staging based on PSMA PET scan, and if the patient had prostatectomy or a radiotherapy during their local treatment. So the optimism corrected C index was 0.722, which is quite high. The closer the value is to 1, the better the model. All right, so to the best of our knowledge, this was the first study to compare radiomic, clinical, and combination models in a cohort of biochemically recurrent prostate cancer patients. What we saw is that the clinical feature-only model outperformed all the others. While we did see that 76% of individual radiomics features were correlated with overall survival, they did not show added value in the multivariable models. So why might this be? Well, the clinical features, specifically staging and aging, were already strong or stronger predictors in comparison to those radiomics features. So when we added the radiomics features in, we're potentially replacing more prognostic features. It also could be due to variability in tumor segmentation or a lack of standardization in imaging, as variations in segmentations or the images can actually change the radiomics features a fair bit. And also possibly due to tumor heterogeneity, which could affect the consistency of radiomics features. So to compare this to some previous studies, we see that these first 3 studies found that radiomics features were in fact correlated with overall survival in prostate cancer patients. So this aligns with the results of this study. Whereas the next 2 found that they were not correlated. And this final study showed that a combination model with radiomics and age achieved the highest C index when compared to just a clinical model and just a radiomics model, which again is different to the results of the current analysis. So what we do see is that many of these studies have a very small sample size, which could reduce the statistical power. And the current study did compare radiomics features to clinical features, which many of these studies did not. So even though they came out as significant, we found that clinical features were actually more significant than the radiomics features alone. A few limitations. So this was a retrospective study with quite a small sample size, so this limits generalizability. So even though we did sample size calculations, some other calculation methods suggest that a much larger sample size is needed, closer to 300-400, whereas we had 180. So some future work would be validating these findings on a larger, more diverse data set for better generalizability, potentially exploring advanced feature selection techniques such as unsupervised clustering to try and reduce the number of radiomic features going into the multivariable models. Also developing a clinically accessible tool for clinicians to use to try and stratify the patients early on in their disease to try and aid in personalized treatment options. Okay, so now this brings me to our second aim, which was assessing progression criteria for predicting overall survival and PSA progression-free survival. So we have 2 prominent progression criteria for prostate cancer, which is based on PSMA PET CT imaging. The first being the PSMA PET progression criteria, which is PPP. They define progression as the patient having 2 or more new lesions between the baseline and follow-up scans, or 1 new lesion with consistent clinical or laboratory data, or no new lesions, but an increase in size by more than 30%, or an increase in uptake by more than 30%. The second one is the response evaluation criteria in PSMA PET CT imaging, which is RECIP 1.0. They have defined 4 categories, with the RECIP progressive disease category being defined as a 20% increase in the volume of the tumors, as well as an appearance of new lesions. So on the right, we see an example of that. We see both new lesions and a size increase, and they have some other definitions, for example, partial response, where they have a decline in the number of lesions and the decline in the volume. So just to compare PPP and RECIP progressive disease, the patient on the left has progressive disease defined by PPP only. We see that they have a single lesion, and that lesion has grown in size and volume. On the right, we see a patient with 3 lesions to start with and many new ones. So they've experienced both a size, a volume increase, and new lesions. So therefore, they are progressive disease by both PPP and RECIP progressive disease. Okay, so the methodology for this section. This time we had 120 patients receiving treatment. So we did not include the active surveillance patients in this part. We only included patients who were receiving treatment. We then categorized the patients by progression criteria using their baseline and follow-up scans. So because PPP had various definitions of progressive disease, 3 were used in this case. So we had PPP volume, which was defined as an increase in volume of the tumors. And then we had mean SUV and max SUV, which was defined as an increase in the mean or max SUV between baseline and follow-up scans. And then also RECIP 1.0. Next, PSA data and survival data was extracted for each patient. And then finally, we correlated the progression criteria with each of these endpoints to see which of them can best stratify patients in terms of high risk or low risk based on these endpoints. This analysis was then repeated, and we stratified patients by the treatment type. So looking at how the patients were classified, so according to these 4 criteria, only 17 were classified as progressive disease by RECIP, and we had many more by the PPP criteria. Looking within those RECIP categories, we see that they are fairly distributed, with most of the patients being in the stable disease cohort. Okay, so taking a look at the first part of the results. So the left is the overall survival analysis, and the right is the PSA progression-free survival analysis. So what we see here is that the progressive disease group has a much poorer survival probability than the complete response group, and that same pattern is seen in the PSA progression-free survival analysis. We see that in the first 4 years, the stable disease, the partial response group has not experienced any progression, whereas the stable disease group has, and then this begins to cross over in later years. Whereas we see that these 2 groups cross over quite significantly in the PSA progression-free survival analysis, as this is not as a definitive endpoint in comparison to the overall survival. Okay, so the next set of results is comparing each of the PPP criteria with the RECIP PD criteria. So we see them listed on the left here. What we can see from this plot is that the RECIP progressive disease group had the highest hazard ratio for the overall survival analysis. So what this actually means is that the patients in the progressive disease group have 4 times the risk of death occurring at any time compared to the non-progressive disease group. And we see here that they have a median time until death of 61 months in the progressive disease group, and the median time was not reached for the non-progressive group. And then in the PSA progression-free survival analysis, we saw that it was 25 months until PSA progression, versus 58 months until for the non-progressive group. We also see that PPP mix SUV was not significant in this case, as it's crossing over this line, this one line. So on the right is an example of the PPP mix SUV. We see that the 2 lines here somewhat cross over, especially the confidence intervals, and the log rank tests showed that they were not statistically different from one another. Whereas for the RECIP progressive disease group, we see that the 2 groups are distinctly separated, as in the survival distributions are very different from one another, with a p-value of less than 0.05. Okay, and lastly, the treatment-specific analysis. So we see here that the patients received a variety of treatments, with 95 receiving ADT, androgen deprivation therapy, and 54 receiving radiotherapy. We also see various combinations of different treatments. So in the ADT patients, we again saw that RECIP progressive disease had the highest hazard ratio and the smallest p-values, indicating that it was the most prognostic. However, in the radiotherapy patients, we saw that the mean PPP mean SUV was actually the best at identifying these high-risk patients. So this is possibly due to the fact that there are much fewer radiotherapy patients with 54, and many of them also received ADT, so it could be skewing the results slightly. It also could be due to the different reactions of the tumors reacting to radiation in comparison to ADT or other treatments. All right, so what we found is that the RECIP progressive disease was better at classifying patients in terms of both overall survival and PSA progression-free survival. This means using just baseline and follow-up scans, patients can be identified as high risk early in their treatment regime. However, we did see that the treatment-specific results were less definitive. So taking a look at some other studies, these first 2 studies here showed that PPP is prognostic for overall survival, and our results also showed that PPP was prognostic. This third study is when RECIP was developed, and the study by Ga-PSMA et al. Showed that RECIP 1.0, or RECIP progressive disease, was better at identifying high-risk patients in comparison to PPP and some other traditional methods. The next series of studies here showed that RECIP progressive disease was in fact a prognostic for overall survival and PSA progression-free survival, which also aligns with the results of my study. But this final study, which was released earlier this year, showed that neither RECIP progressive disease nor PPP was prognostic for overall survival in hormone-sensitive prostate cancer patients, which is very similar to the cohort of patients used in this current study. Now, it is worth noting that there were only 42 patients here, so again, the statistical power may not be as high, but this is interesting and necessary to consider as it is different to the results of the current study. Okay, so a few limitations. Once again, it was a retrospective study, and we had a very heterogeneous cohort in terms of the types of treatment that the people received. We also have a small sample size, especially when we do the treatment-specific analysis. So future work may involve repeating the analysis on a larger, more homogeneous treatment cohort, and also possibly combining RECIP-PD with some of those highly prognostic radiomic or clinical features that we found in aim A of this study. So to conclude, I just wanted to emphasize the difference between standard medicine and personalized medicine. So typically we have a patient cohort, they are administered treatment, and we see some patients will have a positive response and some will have no effect or an adverse effect. By enabling some of these techniques, it can lead to personalized medicine, where we stratify the patients based on either radiomics, clinical features, predictive modeling, or some of the progression criteria, and we classify them into groups. And we can say that this group may benefit from hormone therapy and chemotherapy, whereas another patient group may benefit from radiotherapy or surgery. And the hope is that each patient can get the treatment that works best for them, and they will all have that positive effect. So just to sum up, we found that clinical features can be used for model development to identify patients at higher risk of death using just a baseline image. We also found that RECIP progressive disease can identify patients at higher risk of death and PSA progression using their baseline and follow-up scans. And this can lead to this personalized medicine and hopefully improve these outcomes for these patients. So just a few acknowledgements. I want to say again a huge thank you to my supervisors, Jake, Martin, and Natasha, and also a huge thank you to Pejman for teaching all of our students the entire of last year. I've learned so much from you, and I'm really grateful to have been able to be your student and get help from you all the time. I want to say thank you to Nathaniel and Jake for running the machine learning in cancer research cluster every week and taking time out of your busy schedules to help me and the other students getting through all coding issues. Thank you to my peers. It's been lovely getting to know you all over these past 2 years. To Suki Gill, Jeremy Ong, Rosin Francis, and Stephen Vanderwerf for helping with clinical insights and some of the research preparations. And also a huge thank you to the Charlie's Foundation for Research and the UWA Data Institute for providing funds to support this research. And that's opened up so many opportunities for me that wouldn't have been possible before. So thank you very much. Just some references, and thank you. That is all from me.
Brilliant work, Kaylee. Thanks very much for that presentation. We'll now open the floor to any questions. Martin, you've got your hand up there.
Yeah, thanks, Kaylee. It's a really fantastic work and presentation. So a couple of questions. The first one is on the response criteria, like the radiotherapy, or the PPP criteria better predicted the progression-free survival for radiotherapy. Is that because of the example you showed? It's because radiotherapy is typically localized to the prostate or the pelvic nodes, and really you're just looking at maybe a change of volume there rather than a change in the number of lesions.
Yeah, that's definitely possible. The patients had received either prostatectomy or radiotherapy in their initial treatment. So yes, they could be going through a second round of radiotherapy or to the nodes surrounding. So yeah, that's true. It may be that just the tumor may have shrunk slightly in that specific region.
Yeah. And the other question is, you use retrospective data, which is from, you got no control over the quality and the timing, etc. So if you were to do a prospective study design a prospective study for that first aim,
Hmm.
do you think the ideal timing would be for the imaging?
Um, hmm. I think imaging the patients shortly after their diagnosis of the biochemically recurrent prostate cancer could be most effective, as at that stage, not all patients will have experienced metastatic disease, but biochemically recurrent prostate cancer is a strong predictor of future metastases. So if we had images at that very early stage, we could see if we could predict the um, the future the appearance of metastases. So I think that could be most beneficial.
What do you think the benefit would be? What could you do?
Um, by having a prospective study.
Yeah, well, by having, if you do the prospective study and you show that you can predict early on, what's the benefit for the patient in that case?
Oh, so that way we can identify patients very early in their diagnosis as high or low risk. So if we can do that, then a patient with, say, a higher risk, they could go onto a different treatment course or a more aggressive treatment course, and possibly their outcomes could improve because they've been identified as higher risk very early on in their treatment.
Thanks.
Thanks, Martin. Were there any other questions for Kaylee? Okay, no one's putting their hand up. So I'll jump in with a few of my own questions, Kaylee, if that's all right. So you mentioned the comparison to the Gucci et al. Study,
Yes.
and the differences in terms of why they identified specific features as being predictive, whereas you didn't. I'm just wondering if the distinction here is related to the treatments that these patients underwent, right? So in this case, we're talking about castration-resistant prostate cancer patients, and my guess, and I think this is a pretty solid guess, is that most of them were undergoing lutetium PSMA therapy.
Yeah.
Now, I guess the difference there would be that PSMA is targeting the actual receptor that's being imaged, right? So you would kind of expect that there would be some features there that are predictive of response. Do you think that's a factor in terms of the differences between your study, for example, and the Gucci et al. Study?
Yeah, I think that definitely would be a factor. Yeah, the patients have a more advanced disease, the metastatic castration resistant, so they've passed the point of traditional treatments working well for them. So yeah, it's definitely possible that because the different treatments, the different level of disease progression, that the results might differ. And there haven't been that many studies on early cohorts, so this is one of the few looking at a much earlier disease stage. So it's definitely possible that the results in an early disease stage might differ from those at a more advanced stage.
Yeah, and I'm also sort of thinking that because the treatment is directly targeting exactly the same receptor that we're imaging, that there would necessarily be some features there that would be predictive of response.
Yeah.
Whereas that's
Yeah,
not
that's
the
true.
case in our cohort.
Yeah,
So
true.
a couple of other questions. Actually, maybe just a follow on from something that Martin said, which is regarding the differences in the PPP and the RECIP for patients who had radiotherapy. I'm just wondering if you think it might be a disease volume thing. So perhaps radiotherapy patients are more likely to have a lower disease volume, disease that's much more localized and can be feasibly treated with radiotherapy, as opposed to those who are put on systemic treatments like androgen deprivation therapy. Do you think that was a contributing factor?
Yeah, I think that also definitely could be a contributing factor, because radiotherapy is probably only given to those patients with fewer tumors, and maybe having a lower disease burden might actually, it might be that the maximum SUV, or I think it was the mean SUV, the mean SUV actually may have better identified the patients at high or low risk, because possibly due to there being fewer lesions there.
Yeah, I'm just thinking about the application of these response assessment frameworks, and it might be that, for example, the PPP is more useful patients with a lower disease burden than RECIP is, and in fact RECIP was basically designed for patients with a high disease burden anyway.
Yeah.
So that could be a contributing factor. Maybe I'll just go with one more question. So your model where you aggregated features at the lesion level to predict patient level outcomes essentially turned out to be negative, right? So the radiomics features didn't really provide any additional value to the clinical features. Do you think it's possible that we would have more success if we instead tried to predict a lesion level response? So instead of sort of predicting how the entire patient's going to progress, maybe predicting how individual lesions might respond to any given treatment?
Yeah, I do think so. I think that in the methods that I used, I was identifying the largest lesion or the hottest or a weighted average of the top 3. But that doesn't necessarily represent each lesion by itself or an overall disease burden. So I think if we could extract radiomics features from each lesion and then assess that based on the follow-up scan, we could potentially investigate like a lesion level response if the tumor has grown or decreased. So I think that could also be maybe the next step, future work for this study.
Yeah, definitely. I'm thinking specifically it'd be very useful to be able to predict in advance, for example, which lesions won't respond to androgen deprivation therapy, which could potentially be, targeted for SABR or something like that. But yeah, definitely some future work there.
True. Yeah.
Excellent. Thanks, Kaylee. I'll stop my questions there. Pejman, did you put your hand up before for a question?
I had 2 questions, but Kaylee nicely answered those questions during the presentation. Very well done. Nice presentation. Impressive work. I need to congratulate you and your supervisors. So well done. Excellent. Very high standard.
Yeah, thanks very much.
Thanks,
Paul,
Pejman. I think Paul has a question.
Yes, hello, can you hear me?
Yes.
Yes, excellent. I work in Charlie's nuclear medicine and PET, medical physicist there. So thank you for your presentation, Kaylee. That's very interesting.
Thank you.
One thing I wanted to ask about is when in our theranostics meetings that we have, we often look at the differences between FDG PET and PSMA PET in terms of response of tumors. A lot of the ones that are poorly differentiated and don't have as much, PSMA receptor binding capability will show up, and patients that have FDG avid lesions that aren't also PSMA avid have a poorer prognosis in terms of our therapy that we give, which is the lutetium PSMA. Are there any thoughts about perhaps including FDG PET in the analysis here to see whether any of the branches off to particular types of therapy might be more useful than others?
Yeah, in this cohort we only had the gallium-68, but I think in a future trial, if we had both the gallium-68 and the FDG PET images, and we were able to compare them and see which radiomics features from each of those images performed better, I think that could be really valuable then to try and stratify those patients and see which ones may perform better with those different types of treatments. And I think having more information about the patient, having both scans, would be just having more information. We could make more outcomes from those scans. So I think it would be really valuable to possibly have both of those images for this assessment.
I can understand that will be an extra complication because it probably adds a whole new dimension. But I think that there's probably plenty of data that might be something that could possibly be investigated.
Yeah, that's a good point. Yeah, thanks for that.
Thanks.
Excellent. Thanks, Paul, and thanks again, Kaylee. I think that's all the questions we have for you today. So again, very well done on an excellent master's project.
Thank you very much to everyone.
Well done, Kaylee.
Thank you.